Hello and welcome to another session of our 108 Harley Street CPD Snippets program. You should all be familiar with the format by now. This is going to be 12 slides spanned over about 20 minutes and a short quick burst CPD session about a topic. Today I'm going to be talking about thoracic outlet syndrome. We've had a fair bit of interest about this topic, and I know that there is a fair bit of controversy about the management of thoracic outlet syndrome, so I thought it would be something good to talk about. As always, if you had any comments, questions, feedback during my talk, if you want to send us questions on this email, I will try and respond to you as promptly as I can. It's important to start with the anatomy here. So the thoracic outlet is this bony cage that you can see on the anterior aspect. You've got the manubrium sterni, you've got the first rib and the T1 vertebra. So this is the thoracic outlet. It's a slight misnomer in that we call it the outlet because the only thing that's actually going out from the thoracic cavity is the subclavian artery. The subclavian vein is actually going into the thoracic cavity, and the brachial plexus just traverses our space of interest. Important muscles to remember, especially in the context of thoracic outlet syndrome, are the scalene group of muscles, the anterior scalene, which attaches to the inner aspect of the first rib, and the middle scalene and the posterior scalene. This is why it's important. This is the area of interest, the scalene triangle, where the subclavian artery and the brachial plexus exit or traverse. The subclavian vein actually sits anterior to the anterior scalene muscle, bound by the costoclavicular ligament and the subclavius muscle. And here you can see a diagrammatic representation of the artery and the brachial plexus. This is a good picture of the first rib. Taking back to anatomy days, you can see the scalenus anterior attaches to the scalene tubercle of the first rib. On the inner aspect of the rib, you've got the groove for the subclavian vein here, which is where the subclavian vein passes over the flat surface of the first rib, and the groove here for the subclavian artery and the brachial plexus anterior to the scalenus medius muscle attachment. Thoracic outlet syndrome is when we talk about thoracic outlet syndrome, we talk about three parts or three types of thoracic outlet syndrome. Neurogenic type, or NTOS, which is essentially the commonest variety that we encounter. So 95% of cases of thoracic outlet syndrome are neurogenic. And we think that there is a repetitive stress injury that causes the neurogenic phenomena to develop. And this is because we've identified that there are certain at-risk populations, so people who sit on the desk and type quite a lot, swimmers who utilize this area around the shoulder girdle, who are associated with sort of a higher incidence of neurogenic TOS. The peak incidence tends to be around the 25 to the 45 year mark, and surprisingly for this type, 70% of neurogenic TOS tends to affect women, so it's got a significant female preponderance. Symptoms that these patients present with can be arm pain, paresthesia, weakness, and this could involve the entire brachial plexus or the individual radial, median, or ulnar nerve patterns. The second variety of TOS or thoracic outlet syndrome is the arterial variety, which is responsible for up to 2% of cases. And again, this is a repetitive injury to the artery, which causes a fibrotic thickening of the artery, which may progress to intimal injury, stenosis, and a post-stenotic dilatation and aneurysm formation. So when the arteries are involved, this is what we worry about. In the context of the subclavian artery, when you get aneurysm formation, It's not rupture as much that we worry about. We worry more about distal embolization, because as you can understand, flow dynamics change through the artery, where sort of a tube is transformed into a slightly voluminous area, and the laminar flow pattern is disrupted. As a consequence, you can get clot formation along the peripheries, which can embolize. So these patients can present with hand symptoms, so pallor of the hand, paresthesia over the hand, especially cold hands, and some of them may actually have classic Raynaud syndrome. And that why this is important is if patients present with unilateral Raynaud syndrome, we should really assess the whole of the arterial supply of that limb, because you may be able to still feel pulses, but if you do scanning, when you investigate, you may pick up aneurysmal change, and then further investigations may confirm a diagnosis of thoracic outlet syndrome. Another variety of thoracic outlet syndrome is the venous thoracic outlet syndrome, which is responsible for up to 4% of cases. You may have heard of the term Paritosh syndrome, which is important and quite relevant in this context. This is essentially either spontaneous or effort-induced primary subclavian axillary venous thrombosis. So these patients present with DVT in the upper limb, which is either spontaneous or with effort. So I've seen quite a few patients like this who will be quite young. So the average age at presentation is about 30 years. This tends to be commoner. This variety is commoner in men and almost 3 times as common on the right side as opposed to the left. So these patients usually will have a history of weightlifting, using the upper body quite a lot. They do a fair bit of upper body work in the gym, and they will present with sudden swelling, cyanosis, and prominent veins, especially around the shoulder girdle region. And that's where the venous collaterals have developed. So you can see predominantly quite a few veins, and the color of the skin is different compared to the other arm. How do we get to the diagnosis? The history usually is quite typical, that we can pinpoint that there is a problem. So they will have sort of paresthesia over the area, or if it's arterial, they may have pallor or Raynaud's symptoms. If it's venous, then they may have swelling, so it may fit with the diagnosis. Some of you may be aware of these provocative tests, the Roos, Adson's, and Wright's tests. All of these tests essentially reduce the costoclavicular space and provoke symptoms. So the Roos test essentially is surrender sort of position. You ask the patient to open and close their fist for about a minute or so, and this leads to development of symptoms. Similarly, the Adson's and the Wright's test, which provoke symptoms. Investigations available to us include an X-ray, a duplex, CT scans, MRI scans, fluoroscopy sometimes, which is quite relevant, and also nerve conduction studies, which is particularly important for the neurogenic type of TOS. Got some pictures for you. So here, this is a good picture of a cervical rib. This is a bony sort of abnormality that may be responsible for thoracic outlet syndrome, and these patients need surgical correction. Here you can see a duplex image. On the left, the A image is in the normal arm position by the side, where you can see flow in the subclavian artery with normal waveforms. But as soon as you raise the arm, you lose flow completely. So this is quite diagnostic with just the raised arm. You have to keep in mind that these tests sometimes can be difficult to interpret, especially in the extreme surrender position, because quite a few people, even without or in the absence of thoracic outlet syndrome, will lose their waveform in the extreme surrender position. So this has to be taken in context with the history and other investigations. CT and MRI scans may demonstrate extrinsic compression of the artery or the vein, as the case may be. This is a venography picture of a lady who had presented with DVT of the upper limb in the subclavian artery. You can see the picture at the top is a venogram through the basilic vein, where you can see almost normal flow pattern, but as soon as you raise the arm, you are seeing a significant stenosis where blood does not flow through, and you've got a prominent cephalic vein there as well. So these images are fairly diagnostic in these patients. So when you take it in conjunction with the history, you can confirm a diagnosis. So how do we manage these patients? Neurogenic TOS in particular is difficult, and the recommendations are that in the first instance we should manage this condition conservatively or with non-operative means such as physiotherapy, postural exercises. We ask the patient to avoid heavy lifting and avoid activities involving lifting the arm over the shoulder region. In the absence of an improvement, some of these patients will benefit from decompression of the thoracic outlet, which, depending on the case, it may be a cervical rib resection, a first rib resection, or if they have a congenital fibromuscular band, which may be responsible for their symptoms, they need a scalenectomy and resection of the fibromuscular band. In cases of venous thoracic outlet syndrome, these patients, if they present acutely with a DVT, will undergo thrombolysis, which is an accepted form of treatment for these patients nowadays, where you treat them with a clot-busting drug, and then this is followed by definitive surgery if we identify that there is a thoracic outlet syndrome, that they undergo surgery to remove the first rib and a scalenectomy at the same time. In cases of arterial thoracic outlet syndrome, these patients would require aneurysm repair, which is extensive surgery, plus in addition to the first rib resection. Thank you. As usual, any comments, questions, referrals, you've got the emails on your screen, and I'd be grateful for your comments. Thank you for listening.